I am presenting a case of 29-year-old serving soldier in Indian Army who was admitted in our hospital with chief complaints of generalized swelling all over the body for 1.5 months duration, shortness of breath on exertion on and off since 10 to 15 days, and frothing of urine of around 1 month duration. My history dates back to March 2021 when he had complaints of uh, severe headache. What he described was the worst headache of his life, which was associated with visual blurring and non-projectile bilious vomiting, for which was admitted to Command Hospital, Udhampur, and there he was diagnosed as to be having some blood clots in the brain, as he reported, and he was given blood thinners, which he doesn't remember during that time. Subsequently, he was put on apixaban 5 milligrams OD, which he remembers. During this evaluation, while he was in the hospital, he was diagnosed to be having protein leak, a proteinuria of around 42 grams per day, which the value patient which is the value which patient remembered, and along with that, he also had bilateral pedal edema, which was extending up till knees, and he was having on and off shortness of breath as well. There was no history of any trauma to the limb. There was no history of any prolonged exercises or heavy exercises, which he did just before this set of symptoms began. He was given some treatment in that hospital, and a kidney biopsy was also done at that time. The report is not remembered by the patient, but he stated that his weight was taken and he was started on tablet prednisolone 60 milligrams per day at that time. While he was started on this treatment, within 20 to 25 days of starting him on prednisolone, his symptoms improved. He had symptomatic improvement in terms of the pedal edema, which subsided, the frothing in the urine, which also subsided. Then he was put on daily 60 milligrams of prednisolone, and which he took for about two months, following which it was tapered and subsequently stopped over next 2 months. He was symptomatically alright and he was resuming his duties in the army. But in December 2021, he again complained of similar symptoms. That time he was around 2 to 2.5 months off steroids. In December 2021, he again started having similar symptoms of frothing in urine associated with bilateral petechial edema, periorbital puffiness. This time he had shortness of breath, which was worse than before. And there was no history of any chest pain, ghabrahat. There was no history of any decreased urine output that time. He was subjected to some. Then he was again admitted to our hospital. He was subjected to some investigations, and as the patient told to us, he was diagnosed to be a case of tubercular pleural effusion.
When did he come to you?
Sir.
When did he come to you?
Sir, December 2021. Again.
He came the first time also?
Yes.
So you,
yes.
from Udhampur he came here?
He came. He was transferred here.
Okay.
Then he was subsequently discharged, and then he came back to us again in December 21.
And when he came back, was he still on steroids?
No, ma'am. He was off.
Stopped at
Yeah, 2 months off steroids was the period. In December 21, he was diagnosed to be having tubercular pleural effusion, which he says that some tests were conducted on his pleural fluid, and he was started on 4-drug ATD with effect of 1st February 2022. This time, when he had he was recently diagnosed as a case of extrapulmonary tuberculosis, he had a proteinuria of 39 grams this time, and he was again with serum albumin of 1.2 milligrams per deciliter. He was restarted on high dose steroids 60 milligrams per day again, which he consumed for around 3 months. After this patient was on our follow and was admitted with us But despite being on 1 milligrams per kg of steroids, as reported by him, his proteinuria did not improve. He still continued to have frothing in urine and on and off pedal edema. The patient was decongested with good diuretics and albumin, following which the pedal edema improved. However, serial proteinuria evaluation, which was done, 24-hour urine quantification was done, now revealed a proteinuria of around 30 grams.
When was this? After how many months?
And 3 months.
39 to.
3 months.
And he continued with 1 milligram of steroids in these 3 months?
Yes. 3 months full dose was given, ma'am. For these 3 months full dose, despite being on full dose steroids, he continued to have nephrotic range proteinuria. Following which the management was changed, and this time he was started on tacrolimus in dose of 0.5 milligrams PD to start with, and he was continued on 30 milligrams of prednisolone as stated by the patient. Patient also reports that while being on tacrolimus for around in these doses 1 milligrams per day, he was subjected to a C0 tacrolimus levels from a civil institute, and the levels came out to be low, which he doesn't remember the exact value. So the dose of tacrolimus was hiked up from 0.5 PD to 1 and 0.5 milligrams PD. This treatment in form of CNIs plus low dose prednisolone was continued for 6 months, while serial proteinuria evaluation was done on monthly basis. After 6 months of this treatment, a repeat proteinuria which was done suggested 22 grams of proteinuria along with albumin of 1.6. In view of his persistent nephrotic range proteinuria, he was then given treatment rituximab 1 grams, 2 doses, 15 days apart.
Besides steroids and tacrolimus, was any other medicine given here?
No.
Apixaban was stopped or continued?
If apixaban was continued through all this time, it is being given now. Patient also reports that after 15 to 16 days of last dose of rituximab that he received, a CD19 levels was sent for him. The patient's educational profile is MA, so he remembered all these things, and he reported to us that a CD19 levels was done 15 days post rituximab. The value he doesn't remember, but this rituximab was given in October 22, and in December 2022, a repeat proteinuria evaluation which was done and all this time he was in hospital only, which was subsequently done, and it showed proteinuria of 17 grams. Even after getting rituximab 2 doses, still his proteinuria was 17 grams per day. So he was then started on modified treatment in form of low dose prednisolone 30 milligrams, tacrolimus, and another drug MMF 1 gram PD was added since December end 2022, in last week of December 2022. He doesn't give any history of joint pains, oral ulcers, photosensitivity, skin rash. He doesn't give any history of flank pains or lower urinary tract symptoms in form of voiding symptoms or urgency or hesitancy of urine. There is no history of chest pain, ghabrahat or palpitations. There is no history of headache or seizures or vision blurring post that one episode of headache that he had in the beginning of his illness. There is no history of any nasal bleed, nasal thrusting, upper respiratory tract symptoms, skin tightening or dysphagia. There is no history of any alternative or complementary drug intake. There is no history of NSAID abuse. There is no history of weight loss or low-grade fever or loss of appetite through all this period. There is no history of any prolonged immobilization, no history of buffalo hump or stry over the abdomen, no history of bony pain, psychiatric disturbances, dyspepsia or abdominal pain. Past history. There is no history of tuberculosis or hypertension prior or diabetes prior to
What
onset of.
happened to his ATT? How many months it took?
And the ATT was started from 1st of February, ma'am.
Continued till?
We are giving him 9 months.
And his fluid subsided.
Yes, ma'am. Ma'am, we are very congested. Past history, there is no history of any other chronic illness, no history of any kidney-related disorder in the past. Personal history, he is vegetarian, pure vegetarian by diet. No history of any high-risk behavior, no history of any tattooing or sharing of infected needles, no history of any substance abuse. Family history is not significant.
What family history would you ask in this man?
Ma'am, I would ask him the family history of the siblings or parents having the same disorder of protein leak or pedal edema.
Any history of renal failure in this man?
No.
Till now his renal functions are normal.
Yes, his renal function has been absolutely normal all this time. Then birth history, he is a normal full-term vaginal delivery, born out of a non-consanguineous marriage. He cried soon after birth, had achieved his normal developmental milestone. There is no history of double voiding or objective voiding in his time. And he also denies any significant antenatal history to the mother.
You know, generally when you say full term, that should be enough. When you say vaginal delivery or a cesarean, it's for the woman. It's not for the person who was born. No, he was born full term, that's all. Huh?
Yes. So, my summary at the end of history taking is a 29-year-old serving soldier without any previous comorbidities developed nephrotic syndrome, and he was given a course of oral steroids to which he did not respond. He responded for the first time, but second time after he had extrapulmonary tuberculosis, he had relapse of his nephrotic syndrome, following which he was given another course of oral steroids to which he did not respond, following which he was given a course of CNIs plus low dose steroids for a period of around 6 months to which he did not respond, and further he was given rituximab 1 gram 2 doses also to which he did not respond till date.
Okay, let's stop here. Now, let's come to the presenting complaint that your patient had. What did he present with?
Sir, his initial presentation was just
Anasarca.
Anasarca and
Anasarca. Headache. Okay, headache
Headache and
also.
neurological symptoms.
So he came with anasarca and headache. So when you get a patient with anasarca, what are the DDs which run in your mind?
Sir,
It's a young person, it's not an elderly man.
sir, it can be due to kidney, it can be due to heart, or it can be due to liver, sir. So in a young patient like him, sir, with presenting with anasarca, sir, I would first try to elicit the history. Where did it start from? Whether it was the pedal edema which came first, or it was the periorbital edema which came first. Sir, firstly, I would also take his
So
history.
you told me three things:
Yes,
heart, kidney, liver.
Sir.
And this man had a hypertensive encephalopathy or whatever crisis he had.
With a looks like an infarct, as you said.
So what do you think it was?
Thrombotic infarct.
Sir, there has not been any history of raised blood pressure records for him, sir. So hypertensive, more than the hypertensive infarct, it looks like some thrombotic event which happened.
Okay, so he came with anasarca and there was no hypertension. If there was hypertension,
Sir.
If
if there was hypertension, would it lead you into any particular diagnosis?
Yes, sir. If it would hypertension, then probably patient was a case of hypertensive nephropathy, which
At this age,
29.
unlikely, sir, but it can be there. Second, there
think
can
of
be
a
some
glomerular
autoimmune.
disease.
Yes, sir.
Think of a glomerular disease
Glomerular.
in which there was hypertension and anasarca.
Sir.
Alright. Now you said your patient had nephrotic syndrome.
Sir.
So what is your definition? Let somebody else answer. What would be
define
the
nephrotic syndrome?
what would be the definition of nephrotic syndrome?
proteinuria more than 3.5 grams per 24 hours would be termed as diagnostic syndrome.
Along with
Along with dyslipidemia, edema, and
edema, proteinuria, edema, and
dyslipidemia.
hypercholesterol.
okay, dyslipidemia and more common
Hypoalbuminemia.
hypoalbuminemia. You would say your patient has got nephrotic syndrome. Now, why do you think this patient had an ischemic infarct?
Sir, the patient's albumin was very low, which predisposes him to having thromboembolic complications that may be due to death.
How common, which part of the body you get the maximum thromboembolism in this kind of hyper? Is it the brain or somewhere else?
No, ma'am, it is mostly deep vein, and venous thrombosis is more common than arterial.
What do you think this was, venous or arterial?
It must be venous, ma'am.
So if you think of any other diagnosis which causes venous thrombotic infarcts, which can present with raised ICP, this was raised ICP.
Yes, ma'am.
So was your patient ever fundus was done?
Yes, ma'am.
What did they say? Was there any papilledema or anything?
No, ma'am.
He had blurring of vision.
He had blurring of vision.
If you ask him that history, that was there any papilledema?
Ma'am, at first, this index event, ma'am, he was having symptoms of raised ICT in form of visual blurring and projectile vomiting.
Yes.
But post that, he did not have any such symptoms.
So it could be a venous infarct. That's what he's saying. Now let me ask the senior batch. An arterial infarct in the brain and a venous infarct in the brain, how do you differentiate the two?
Simple, clinically or
You get the question? Suppose there is venous thrombosis, you get an infarct in the brain. Suppose there is an arterial thrombosis, you get an infarct in the brain. So, what is the common thing we use on the bedside to differentiate the two? Or on a CT or an MRI or whatever?
So the location of the infarct. Mostly arterial infarcts are secondary to the hypertensive beat, and most common that is
going
glutamin.
to that? Because
No
sir is
hypertension.
asking this is related to nephrology. Subcortical arterial infarcts can happen with vasculitis also. So don't just say ki an arterial infarct is hypertension. He is asking venous and arterial, besides location.
So, atypical locations of infarcts, we do not follow a arterial pattern or arterial bed. Think of venous infarcts. Alright? Now, when you said patient was started on apixaban, so somebody thought of nephrotic syndrome, hypercoagulable state, and started on apixaban. Was it the right choice?
No, sir.
Why?
Just because in treatment of anticoagulation in nephrotic syndrome, studies have the studies and RCTs which have been conducted are for warfarin and heparin. They are not for newer anticoagulants or direct thrombin inhibitors.
Why? What is the problem with newer anticoagulants?
Sir, the problem is that we don't have a reversal agent for them.
No, that is not a problem.
Sir,
Your problem is, does it act?
Why does it do that? With low acts, as you said, no, sir is asking what is apixaban?
it is a
Which what group of it? Is it it's a direct thrombin inhibitor, factor Xa inhibitor, what it
it
is?
is factor Xa.
Good. So why is it not used in nephrotics?
Its answer is lying with you. You said it's a factor Xa inhibitor. What happens to factor Xa in nephrotics?
In nephrotic syndrome, it is a procoagulable state because of the protein C and protein S deficiency and loss of antithrombin 3 in the
What
urine.
happens to factor Xa?
It remains same.
Sure. What happened to all the factors?
So the thing you must understand is that all these newer oral anticoagulants, they are protein bound,
Yes.
right? 60 to 80% are protein bound, and they act when they bind to the protein. So when the albumin is not there, their effect goes. There are small case series where they have used newer oral anticoagulants for prophylaxis in nephrotic state, but the current teaching is stick to warfarin, stick to heparin. There is no role for these newer oral anticoagulants. Okay, now At what nephrotic stage will you consider thromboprophylaxis?
Sir, thromboprophylaxis in a nephrotic should be given if there are indications for that. Number one is first, if there is a previous history of a thromboembolic event. Second, if patient is having other predisposition factors for thromboembolism like prolonged immobilization, obesity, any abdominal surgery is there, or if serum albumin is less than 2 grams per deciliter, then
So the thing is that if there is nephrotic range proteinuria, and if the albumin levels are less than 1.2 to 1.5, irrespective of the predisposing factors, you start them on prophylaxis. But when the albumin levels are higher, but there are predisposing factors like you mentioned, obesity, surgery, immobilization, yeah, and heart failures. Don't forget that. You must put them on prophylaxis. How do you start anticoagulation on your patients?
sir, starting of anticoagulation, sir, we always start heparin and warfarin together. We have to overlap.
Let me ask someone else. Why do you overlap?
So because warfarin takes longer time to act. So basically, before we start warfarin,
There is no urgency. Here's a man who's come as a nephrotic syndrome walking around. He doesn't have an episode of thrombosis. So there's no urgency to start. But why do you overlap?
Sir, because ultimately we want to shift the patient to warfarin.
Why do you overlap? Why do you say 48 hours, 72 hours, overlap?
Why don't you just start with warfarin and leave it as that?
Because when you give oral anticoagulants, you're creating a hypercoagulable state. You're worsening it. That's why you're giving heparin to these people to block that state. And then give the oral anticoagulant.
It's not because it takes 7 days to act or 5 days to act. It's not like that.
Okay. So then you said kidney biopsy you don't want. You want to tell us the
He
investigations
doesn't know
later.
the kidney biopsy. What do you think should have been the kidney biopsy?
Sir, kidney biopsy. Kidney biopsy should be a FSGS.
No, do you know the kidney biopsy finding?
I know that.
If you know, then tell us so that we can proceed further. Okay. Anyone
Why
who
not
comes with such
membranous? Because which disease has maximum proteinuria? 30 grams, 40 grams.
Actually, we did a serum PLA2R.
Is PLA2 and everything?
He'll tell us. Okay, let's stop at this. We won't see the investigation. I just want to clarify basics first in nephrology. You said your patient responded to steroids. What is the definition of a responder?
So, the steroid responsiveness is like when the proteinuria subsides when the patient is started on protein.
Subsides to what level with what testing?
After initiating on
Is it used in adult or children? This definition.
both adult and
But commonly used in?
Commonly used in children. Less
so for
than 12
adult
years.
should be within 16. Maximum responder is within 4 weeks, but you can extend the dose up to 16 weeks.
So once just give us the definition at what dose, what investigation, for how many days, how many duration or how many weeks?
1 mg per kg we have to initiate.
For children, besides 1 mg? Is children 1 mg?
So if you are reading KDGO, they have sort of changed the definitions. Instead of giving you 1 mg per kg or 2 mg per kg or per meter square, earlier we used to read 60 mg per meter square. No? They've changed it. So they're saying in the usual recommended doses, right? So responders are those who respond within 4 weeks, right? Those are steroid responsive. What is steroid resistant?
Steroid resistant nephrotic syndrome is defined as proteinuria which persists more than 3.5 grams per day despite giving despite giving patient of 1 milligram per kg maximum 80 or daily doses or 1.5 milligrams per kg maximum 120 milligrams of alternative steroids for at least 16 weeks.
So maximum in adults you're going for 16 weeks. So we are confusing these two, children and
In
adults.
children,
Children 8 weeks.
6
4
weeks.
weeks, 6 weeks. So what are partial responders?
So partial response are less than 50% reduction of proteinuria.
That's in adult children. Children, see, how do you say children are responding? Do you calculate this protein urine collections is so difficult? So how do you say that this child is responding? How many lipsticks?
3%.
Then this man responded apparently,
Yes.
and then he relapsed. So what are the definitions we use for relapse?
So relapse is after 1 month of
No. What are the types of relapses?
Frequent,
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 infrequent,
and complete.
and steroid dependent. So what is the frequent relapser?
So frequent relapser is one who relapses more than 2 times in 6 months and 4 times in a year.
That is one more line to it.
Initial 6
After the start
Start
of initial therapy.
Yes.
Alright. Okay, what are infrequent relapses?
Infrequent is more than once in 6 months and twice in 12 months.
Okay, and non-responders?
Non-responders are those who do not respond after 16 weeks of therapy in adults.
Okay, so now they've added a few more definitions. They've now brought in the terms of CNI responders and CNI non-responders. So what would that be?
CNI up to 12 months.
CNI responders are those patients in which proteinuria reduction is then proteinuria is less than 0.3 grams per day after giving CNIs. For tacrolimus it is 0.05 to
No, you give them a CNI for how long before you say they are non-responders?
6 months.
6 months. And how long you give before you say they are partial responders?
1 year. at least.
6 months. At 12 months, whether he is complete responder or not. So this term has come in now, CNI responder versus CNI non-responder. Come sit down. Okay. So apparently your man, what did he have? He had frequent relapses, infrequent relapses.
Steroid resistant.
Initially he responded.
How do you define steroid resistant? Is there a category of steroid resistant? There are 2 types of steroid resistance. It's mostly used in children, and that actually helps you in clinical differentiation of steroid resistance.
Steroid resistant nephrotic syndrome.
Initial steroid resistant nephrotic syndrome, when the child did not respond or adult. Second is late onset steroid resistance.
So this is what your patient had. He responded and the second time he is not responding. No?
He has not gone through all those frequent relapse, steroid dependence, then he has not become resistant. He's gone, once he responded, and he is.
Okay. Now you've kept on hitting him with
Lots of medicines.
whoever was the doctor with a lot of medicines. But when you get a nephrotic like this who has first responded and has again come to you with a relapse, what are the other things you must think of which could cause this nephrotic state? Before rushing in for tacrolimus and steroids and everything.
So firstly, I will ensure the drug compliance.
Okay. But he responded. Good.
The second can be that patient is a case of
I wish you had said early drug withdrawal. They relapse faster. But now he's come back to you with nephrotic. So he's at for 6 months.
He was treated for I think
6 months.
Initially 3 months.
Yeah.
And then he stopped. Then 2.5 months
Yeah,
later.
something like that. Yeah. So what are the other non-immunological causes for nephrotic syndrome in a patient with a diagnosed, whatever be the glomerular disease? You getting me?
What are the other nephrotic
Patient has come with nephrotic range proteinuria, but I'm saying the disease has not relapsed. There is something else causing nephrotic
the
range.
diagnosis maybe
There is something else causing nephrotic range proteinuria.
What are the
And especially in your man.
Yes.
um,
Say down. Say.
No,
Loudly,
let's
loudly.
come you.
Yeah.
Let's.
Amyloidosis.
No, why do you think of amyloidosis in a
Just
29-year-old
tuberculosis.
boy?
I think he must be taking
Secondary tuberculosis.
Too early.
membranous nephropathy.
Membranous is primary.
You must think of renal vein thrombosis. No? Which can cause this.
Worsens nephrotic syndrome.
Which can cause this proteinuria. Then anything else you must think of. You must think of the use of NSAIDs, which can cause worsening proteinuria. So this is what NSAID generally comes with worsening kidney function also, but never miss renal vein thrombosis. So before you go in for immunosuppression again, look for do a Doppler, look for renal vein thrombosis. Okay?
All through this, never a second biopsy occur. What are the indications of biopsy in this kind of a situation?
Ma'am, indications of biopsy can be
No, in your patient, would you think he would have needed a second biopsy, or you are okay with the first diagnosis?
Ma'am, all other probable causes of a nephrotic in this patient were ruled out. So we did not offer him a second biopsy.
Okay.
If the first biopsy was MCD,
Ma'am, if first biopsy was LCD, then a second biopsy to rule out maybe FSGS must have got missed. Then at that time we should have offered him.
Okay. So now that you're talking about kidney biopsy, when do you say a biopsy is adequate?
So as per KDIGO, biopsy nitty-gritty biopsy is considered adequate when at least 10 glomuli are seen.
So, which are the diseases where despite getting 10 glomeruli you may miss
FSGS.
one? Which are the diseases where even on one glomeruli you can make a diagnosis? Yeah, good. So, this is about biopsy. Where will you not do a biopsy? Not do means not mandatory to do a biopsy for a nephrotic.
Steroid sensitive nephrotic syndrome in children less than 12 years. Then PLA2R positive membranous nephropathy. Then conditions like Alport's disease, Fabry's disease, and DGBM disease.
Which are diagnosed otherwise.
Otherwise,
So you need
SLE.
not do a kidney biopsy. SLE is very controversial. Don't bring in SLE here.
lupus nephritis, you should biopsy. That's a very different area of.
So don't bring that into this. I know it's given in the KDIGO, but it's not. I don't think it is clearly cut that you don't do a biopsy in the case of lupus nephritis. Alright, that is good. Okay. Then you mentioned something about frothy urine. What is this frothy urine you're talking about?
Sir, frothy urine means that when patient passes urine, he notices froth which doesn't even go on after flushing.
So this is a very colloquial term which is used now very commonly, but please don't mention it in your diagnosis of proteinuria. There should be frothy urine. Alright? Because froth, if you pass urine
Very fast.
in a commode full of soap, you will have frothy urine. So never mention that. Alright?
What are the find out like what are the other substances or things in the urine which can cause froth?
Ma'am, any amphiphilic substances can which have surfactant-like properties can cause foamy urine. For example, amino acids. In conditions of amino acid urea like Fanconi syndrome, there can be frothy urine.
You mentioned your patient developed, we are only sticking to your history, developed pleural effusion. So how would you diagnose the tubercular pleural effusion?
Sir, for tubercular pleural effusion, sir, the pleural fluid cytology should reveal predominantly lymphocytes. The as per light criteria, it should be exudative. Mostly it should be unilateral, and ADA should be raised more than 40 units per liter.
Then you say it's tubercular.
Sir,
Okay. And you put the patient was started on 4-drug ATT.
sir.
What
Was
is the
you-
role of gene expert in such patients?
Ma'am, gene expert.
Pleural
Ma'am, gene expert. The yield is low in pleural
fluid?
fluids because the Mycobacterium tuberculosis is not actively secreted into the pleural fluids.
Okay.
Was your patient a hypertensive?
No, sir.
So suppose, suppose he was a hypertensive and he was started on ATT, what precautions would you take?
Sir, I would like to start him on rifabutane based ATT rather than rifampicin based because
Why?
Acha, let's give us your reason.
sir, because rifampicin is an enzyme inducer, so if patient is hypertensive, already is hypertensive, so it is going to decrease, it is going to increase the metabolism of my antihypertensive drug, which will lead to accelerated hypertension.
So you prefer to increase the dosages of antihypertensives
You prefer that and
rather than switching on to rifampicin. Okay.
in transplant there is a different issue. You can think of tacrolimus, other metabolism. Here it's a question of antihypertensives.
Now, why did you say family history? You asked for kidney disease in the family.
Sir, family history is important in these cases because there are some syndromic familial disorders, syndromic FSGS, which runs in the family. So to exclude that, I think.
Okay.
What do you think? How do you call this as an FSGS or would you give a different name to this class of disease? Forget congenital everything. What are they now classified as?
Syndromic protein
They are called podocytopathies.
photocytopathies.
The word should be podocytopathy. And you read up. What are the podocyte abnormalities that you see in FSGS? In what are areas you have problems in the podocyte?
Ma'am, podocyte stretching and
It's a complete food process question, but what mutations affect which parts of the podocytes? Where all?
ma'am, nephrin, slit diaphragm mutations in slit diaphragm,
Then
glomerular basement membrane,
GBM,
then actin myoskeleton,
that is called
actin
podocyte cytoskeleton.
myoskeleton.
Then
Sorry.
proteins, phosphorus, lysosomal proteins, transcription factors. Many of them are there. Mitochondria. So there are all areas where you can see. Children classify, but for us, why did we ask this for this point? Do you think it is important?
Yes, ma'am. Because if there is some genetic cause of FSGS, then the recurrence chances.
Would you ask this boy for a genetic testing for FSGS?
Ma'am, we had already done.
We don't know it is FSGS. You've not told us. You've not told us the biopsy.
But would you ask on this boy, what is the yield at this age?
Ma'am, yield at this age is not good because if
When,
any
which is the age when you
10 years,
genetic
up
test-
till 10 years of age.
when you get the maximum yield? And first year is the maximum. Isn't it?
So when do you do gene testing in nephrotic
Yes,
syndrome?
If there is a syndrome running in the family, if there is a history of familial
But
FSGS,
did you tell us that? What are the things? Eye, ear abnormalities you didn't talk. Dysmorphism you didn't take.
ma'am, in general,
You've done that in your
ma'am, in
exam.
general physical examination, I have included that. So for genetic testing, sir, if there is a syndrome which is running in the family, if there is a history, such history, then we have to take. And if we are planning or contemplating a transplant, then we would like to do genetic testing to
So
give a
why he wants to do a genetic testing for transplant?
Anybody? Whichever. Sir is asking, why do you want to do a genetic testing for transplant?
Because the recurrence of disease can be as fast as 3 days in a
If no, this is what you said. If the genetic testing is positive, it will recur, or if the genetic testing is negative, it will negative, it will.
Very. Yeah, okay. So one for a transplant, two, if it runs in the families, then
third is for prognostication of the patient. For example, if patient comes as ApoL1 positive, then we'll prognosticate that the prognosis will be worse than the usual.
okay, then
A patient is steroid resistant.
Steroid resistant.
Withdraw all the immunosuppression.
you will withdraw the immunosuppression, not expose him. Maybe your patient has got a gene abnormality and he's been exposed to a lot of immunosuppression. Okay, so I think this is enough. Now you tell us the find this thing, labs.
Clinical nothing there. No?
Then nothing
Blood pressure
there.
ठीक
And the
है.
sarca.
Edema है, ascites
Sir,
है.
I have general physical examination with me. Labs I have not brought, but I can tell.
But
Tell us the
physical
biopsy.
examination
Or tell us the urine finding.
Sir, urine dipstick I had done when I had taken this case. It is showing 3 plus, proteinuria 3 plus. There were no RBCs, no WBCs, glucose and aspirin nitrate,
In
but
the
negative
RBC you do lipstick or you do blood in the lipstick?
blood.
Okay, so in dipstick he said the proteinuria was 3 plus. That's what you said, 3 plus.
Sir.
Is there any correlation between dipstick and quantification of albuminuria? First of all, should you do proteinuria, albuminuria? What is preferred? What should be the difference between the two?
It's a very important question. Is the urine made of protein or albumin?
In adults, albuminuria, pediatrics, protein.
No, you missed the point.
What size asking?
You have proteinuria, you have albuminuria. What does it mean? What is the difference between the two?
Proteinuria will include all other
What are the other proteins?
like paraprotein.
Not paraprotein. Paraprotein is very different.
It will include tubular proteins. No?
If 1 gram protein, how much is albumin and how much is the other tubular proteins in your urine? What contribution of albumin is in your overall protein? And what is the commonest tubular protein which is present in that? Tam phosphate. What is it called? Is there a name for tam phosphate? So sir is asking, how much, what's it, why do you want to do albumin and why do you want to do protein? 24-hour protein. Given a choice, I will do albumin creatinine in nephrotic. Why? Children without this doesn't matter.
Albumin is a major component.
Of the 70% is albumin. And you're looking for leaks in the glomerular vessel, right? But by convention, we do albumin only for diabetics and we do protein for all other kidney diseases. It's only by convention. But otherwise, albumin is more specific. So my question was dipstick, positive and quantification of protein.
Is this related? 1 plus is how much protein, 2 plus is how much. It's just examiners ask you something.
1 plus is 10 to 100, 2 plus is 100 to 300, and 3 plus is
Trace is
Trace.
less than
up to
50.
10.
Then 1 plus, 2 plus, 3 plus. These are actually useless to try to quantify. But you must remember that in some
examiner
books, 1 plus, 2 plus, 3 plus, 4 plus gives you the degree of quantification of proteinuria.
Why is this not important? Given a choice, does the dipstick tell you exactly what is happening? Or is it depends on the flow rate of the urine? Have you thought of it? Why do we do urine protein creatinine and not just dipstick? Why do we do protein creatinine or albumin creatinine? Just do urine albumin and say that's it. I did urine albumin estimation, it was 1 gram. 24 hour. But even in 24 hour, we factored in with creatinine.
Why do we do a ratio?
Ratio to quantify the adequacy of urine collection.
Suppose you have 1 gram of protein and you pass 3 liters of urine, and you have 1 gram of protein and you pass 100 ml of urine.
Is this the same?
You will get fallacious readings. That's why you take a ratio. Alright? And when you have a urine collection, just by looking at creatinine, how do you say whether the urine collection has been adequate or not?
It should be
How much is the inadequate urine? What should be the creatinine?
Ma'am, in normal adults, in females it should be 15 to 20 milligrams per kg, and in men it should be 20 to 25 milligrams per kg. Roughly 1 gram.
1 gram.
So when you ask someone to collect urine, 24 hours urine, and you are not sure whether it is adequate, look at the creatinine in that. But do any of you know how to tell a patient how to collect 24 hours urine for creatinine or protein?
Time collection, how do you say?
How do you do that?
that person has to avoid the first urine in the morning, then start collecting from the second urine, and it has to be collected in the next morning. First passed urine has to be collected.
Oh,
Same
good.
time when he first passed in the morning. If he passes in the 7 in the morning, he should do it again.
Again, yes,
Okay. So your urine only showed 3 plus
Protein.
Protein,
39
nothing
grams.
else. And nothing else it showed. No cast, no RBCs, no WBCs.
Sir, I had done dipstick only, sir. It was showing only 3 plus protein and rest all over mistake, sir.
Okay.
When you have this discrepancy, Massive proteinuria and 3 plus. What else will you think of?
Massive.
You said 39 grams and 3 plus. What could be the other discrepancy when you have some?
It can be other protein which is not detected by the dipstick, for example, light chains,
Have you heard of overflow proteinuria?
multiple myeloma,
They will not be picked up by the.
by normal dipstick.
So in your patient, did you ever think, but it's not because he's 29. That's why you didn't think of it.
Okay. So I think that's about your case that you presented. Tell us the biopsy finding.
Sir, on biopsy finding, I have taken the photograph of biopsy in my
tell
mobile.
us.
Can I
Yeah.
open my phone?
Can't be the concept.
I can read.
Read it.
Really?
Sir, how the antitubercular and the hydrosteroid was started simultaneously? There should be time gap. Because
So-
he had active infection that time and he was started on steroid.
So what history he gave us was that they put him on ATT and after some time steroids were started. That's the history he gave.
20 days.
But her question is, can you start both simultaneously?
Or there should be a time gap and how much should be the time gap? Like how much extra should be?
Steroids, sometimes especially massive pleural effusions and
What are the question to you? What are the indications of steroids in tuberculosis? Are you aware of any clinical situation of certain types of tuberculosis where steroids are actually given? Pericardial?
CNS.
One by one. One by one. Yes, why don't you tell all of them?
CNS tuberculosis.
Which kind of CNS? All CNS or
Meningitis.
TB
not
meningitis.
arthritis? We have a tuberculous arthritis
Tubercular pericarditis.
and
During
In pleural effusions earlier we used to give, but now it's
ocular TB, optic neuritis.
Guaranteed.
Okay, I've tried it.
okay. Now listen to his biopsy, and we want someone else to interpret the biopsy.
The biopsy is as follows. Total 17 glomuli were seen. None globulate sclerosed. Remaining glomuli show focal
Yes,
dilatation.
one moment. Yes,
Sir. Total of 17 glomuli, none sclerosed.
okay.
Remaining glomuli show focal dilatation and congestion of capillary lumina.
Okay.
One glomulus reveals segmental tuft sclerosis with focal intraglomerular foam cell change. No glomerular capillary thickening. No evidence of crescent formation, tuft necrosis, or subendothelial deposits or intracapillary thrombi formation in the visualized glomuli.
This is with stain?
Ma'am, they have just written multiple sections stained with HNE, PAS, massive trichome.
In a tuft sclerosis, which stain will be the best thing for you if you want to really look into the foam cells and the
Mason's trichome. If IFTA is less than 10% of the sample cortex, a few incisipated hyaline cast in the tubular lumina are noted. Minimal focal chronic interstitial inflammation. Arteries and arterioles are unremarkable.
So just can you describe the glomeruli again? So there is
17, only one is
18 are not sclerosed. There's focal dilatation, and there is proliferation of cells.
No sir, no proliferation.
So sclerosis with
One
foam cells?
one short segmental tuft sclerosis with focal intraglomerular foam cell change.
But what about the mesangium in the remaining?
Sir, they have written no mesangial expansion, no mesangial thickening,
Proliferation?
no no evidence of crescent formation, tuft necrosis, any deposits.
Perhaps nothing.
No. IF. IF, they have done all parameters, all is negative, just IgM is showing segmental entrapment.
Kappa lambda both has been done.
Ma'am, both have been done and both are negative.
Both are negative is unusual. No? I think you have both positive or one will be more or one.
Yeah.
Both are negative this time.
But both must be positive. Normally staining takes place with both because they excreted in the urine.
Yes.
No?
You may not have IgG, IgA, IgG are abnormal in the kappa lambda gets excreted.
So both staining take place. Huh? Okay, now who will interpret this biopsy?
Anyone?
It's all right because this biopsy has taken me also by surprise.
EM? Would EM help in this patient?
Yes, ma'am. Ma'am, EM will tell us how much food process effacement is there, whether it is
Is there a
diffuse or-
difference in the FSCS and MCD food process?
Ma'am, the food process effacement in MCD is more diffuse than FSGS.
Is there a difference in podocyte injury between MCD and FSCS?
Ma'am, in FSGS there is podocyte detachment which is not there in MCD.
So we don't have it. And the diagnosis, somebody what did they say?
On this biopsy, what would you say the patient has? Come. No, it's all right. Yes.
What do you think you feel this biopsy?
Sir, actually, might be a case of focal segmental
Why do you say that?
because one glomerulus is sclerosed and it is segmental sclerosis.
So when do you say focal, when do you say segmental?
Focal is less than 50% of total glomerular number.
Okay, and segmental?
Segment is part of the glomerular vessel.
Okay. Now, what type of FSGS do you think this patient has?
What are the types?
Very high collapsing.
Is this the
Say it loudly.
Very high collapsing.
Like if you had a board, you should have shown us.
perihilar, tip, collapsing? Two more. Tip.
He's finished. Perihilar is finished.
Collapsing,
No, no,
tip,
Collapsing.
not otherwise specified. Cellular,
And cellular. So where does this fit in? Not otherwise.
not otherwise specified, isn't it?
So that's where this FSGS treatment fits in. Okay, suppose you get a case, get a case of FSGS. How do you proceed clinically in your mind to find out whether it is primary or secondary?
Will a biopsy help you make a diagnosis whether this is primary or secondary FSCS?
Diffuse food process effacement in primary. Clinically, it will present as nephrotic ring proteinuria.
So
And-
that will be subnephrotic.
Yes, in secondary. And there will be response to steroid in primary and no response to steroid in secondary.
So how do you define, how do you classify FSGS? Primary, secondary, under secondary what are the heads?
Secondary में reflux nephropathy, oligohydramnios.
Secondary for which there is an etiology, no? There is a cause. Secondary for which you think genetic is the cause, and secondary where it is unspecified. Right now, let's come to secondary with the cause. So, what are the causes you think of?
Secondary में
Infection.
I can't say give one or two, others can give. You say
sickle cell anemia, reflux
sickle cell
nephropathy,
nephropathy,
reflux nephropathy,
reflux nephropathy, drugs.
Infections.
What drugs? Any drugs?
Heroin, lithium.
Infections.
Structural identity.
In secondary, you divide them into two. Is it adaptive or is it as a result of some injury? Now, tell me things which cause injury.
reflux nephropathy,
That is adaptive. Oh, okay, reflux nephropathy. Okay.
sickle cell anemia,
Okay. Tell me some drugs.
Is it heroin?
Heroin is one. Tell me drugs which we use in our practice. Pamitronet, okay. Then one by one. Sirolimus, tacrolimus, pamidronate, Any other drugs?
Tyrosine kinase inhibitors.
NSAIDs.
Yes.
So all of them, these drugs can cause, name some infections which can cause secondary FSGS. HIV. Say 1%. Let's common infections you see in your practice. Parvovirus, then CMV, then
COVID.
These are all collapsing. So they all cause collapsing therapy. HIV you said.
so now what is adaptive FSGS?
Decreased number of glomeruli at birth
Correct.
in case of
In that the number is not reduced. The glomeruli are injured. No, here the number are reduced. So like in
oligohydramnios.
don't oligohydramnios. I've never seen a case.
Oligonephronia, sorry.
Oligonephronia.
Renal dysplasia.
Nephrectomy.
Nephrectomy.
The numbers are reduced. The remaining nephrons develop FSGS.
Yes.
No? So these are the common things.
It
Of
will adapt because of less number of nephrons.
reflux. In reflux, they get damaged. Then hypertension. No, they get obesity. So you must think of these causes.
Even cyanotic heart disease, they all cause. You know what sir is trying to say?
Yes.
When you try to adapt with less numbers, you develop injury. That is FSCS. The others are where the disease processes damage your adequate number of nephrons.
And we already discussed when will you think of a genetic cause for your FSGS. In the beginning, we discussed that. The reason why you should always think about it. No?
Does the foamy cells tell you anything?
Lipiduria.
No, lipiduria where should it be in the glomeruli or should it be somewhere else? He says in the glomeruli. When there was a sclerotic lesion, there are foamy cells. So the biopsy was before the CNI drugs. But you said in your biopsy there was sclerosis and there was some foamy changes in the cell. It didn't happen in all the glomeruli, in one glomeruli. Where do you see classical foamy cells? What diseases in the biopsy you see foamy cells?
CNI toxicity, there is vacuolization, vacuolization.
Lipiduria, but the foamy cells in the glomeruli or in the tubular area cast?
Okay, so now let's stick to what you have spoken. Now, he said it was in FSGS. So, what is the standard line of therapy for FSGS in this young adult? Before we come to that, what would be the most common cause of nephrotic syndrome in a child, in a young adult, and in adults more than say 40 years of age? In a child, MCD. In a young adult, if she asked you what percentage?
80 plus.
In a young adult, in an adult say over the age of 40, 45, it would be membranous as a cause. Yeah, good. So, what is the standard line of treatment for FSGS?
Is immunosuppression given to all FSGS patients?
So, which FSGS will you give immunosuppression? Primary FSGS.
And in primary, everybody? What's the role of RAS blockade in this kind of patients?
So there are certain general treatment which you give all nephrotics. One of them is RAS blockade to cut down on proteinuria. Now I'll take you on a different plane before we come back to this. Why do we want to cut down proteinuria? Why do 1%? I really
Why
can't
do you want to
understand.
cut down protein?
Why do you want to cut down proteinuria? Why so much of emphasis on proteinuria?
Toxic.
One person, anyone wants to stand up and say, never mind if you're wrong, why don't you tell us?
So because proteinuria is tubulotoxic, the protein which gets excreted gets endocytosed by the PCTs and there it
So
accentuates.
proteinuria may damage the tubules and cause interstitial fibrosis. But on a clinical basis, can you remember the heat diagram of progression of CKD? Can you remember those squares, the green square, yellow square, orange square, red square, right? So what happens in A3? When there is A3 proteinuria, they are all in the red square. So when you reduce proteinuria, bringing down from A3 to A1, which squares are you falling
They
in?
come down below.
Into the green, orange, yellow squares. Even there, they made that heat management to show you reduce the proteinuria and the kidney progression of CKD is reduced. So what is the standard line of therapy for FSGS? Besides the general, besides control of blood pressure, control of protein, control of lipids, salt restriction, diuretics. We'll come to diuretics again. Oh, let's take diuretics since that is the most common thing that we use. Right? How do you use diuretics in nephrotic state?
Same question. Do diuretics work as effectively in nephrotic state?
Protein body.
Yeah. So how will you give diuretics in nephrotic state? You give it once a day, twice a day, 3 times a day? So twice a day is preferred. Okay. And which type of diuretics are preferred? Loop. Suppose your loop diuretics do not act. What will you add?
Oral to IV convert. We can convert from oral to IV.
Okay.
Amyloid.
They are not acting.
Amyloid.
Would you like to combine it with albumin?
Yes.
No, you are saying it is
IV.
protein bound. Yeah, so combine it with albumin. Then the next step, where would you go? So what I'm trying to get from you is, tell me the total tubule blockade which takes place with diuretics. Where all do they block? What please said, remove your mask. We can't do it. We are all free. Of
First is which one? Proximal diuretics. What are the proximal diuretics?
Good. No, one more.
One more in another sulfonamide drug which works in proximal tubule.
Mannitol.
Not SCG, it's
Mannitol, very good.
something else which we use very commonly.
In the loop, okay. Now distal to the loop, which are the group of diuretics? Thiazides, metolazone, which Madam mentioned. Beyond the distal convoluted tubule in the collecting duct, and potassium sparing diuretics. So when you combine all this, you're giving a total tubular blockade. Anything else which we have now started using?
Which are they?
That's no. Anything else? We are using it for diabetes. SGLT2 inhibitors. They also cause diuresis. Right? Good. Sit down. Now come back to the conventional therapy for FSGS. Idiopathic primary FSGS. Why I'm insisting on the word idiopathic primary FSGS? Because if there is a cause, you treat the cause. If it is secondary, you don't give steroids. You give only RAS inhibitors. So idiopathic primary FSGS. What is the conventional therapy? One person. Yes, madam. Why don't you tell us? Tell me the dose.
Basically, we start same as nephrotic 1 mg per kg per day, maximum 80. If we're giving 1 mg, and if we're giving alternate day, we start with 2 mg per kg and maximum up to 120. We give it for 4 weeks, then if the patient is responding, then we taper down in next 4 weeks. Or we can, if the patient is not responding, we can continue 16 weeks. And then we can taper it down.
So maximum duration of therapy is 16 weeks. Okay. Now this patient did not respond. So what was the next choice? Is using CNIs.
Not cycles, CNIs.
You can use TAC, you can use cyclosporin with low dose steroids. Alright?
Should you be using TAC and steroids together? Is there a rule or what does KDO say?
Ma'am, Kerigo says that tacrolimus or cyclosporin should be given as monotherapy.
Cyclosporin preferably monotherapy or with steroids?
With steroids.
With steroids.
Tacrolimus?
Monotherapy.
So your patient had both.
Yes. Tacrolimus plus steroids.
When should you start that? This is resistant.
Yeah, okay. So how long will you give this?
6 months.
6 months to look for partial response, and before you say not responding, how long?
12 months.
You will give it for 1 year.
If you respond, then how many years?
2 years.
Even partially?
2 years.
What happens after 2 years if you stop it?
They
Is
tend
there any
to
rate of relapse you are aware of? What happens?
I will see.
No. You, sir said give 6 months. No response. Withdraw. Give 6 months. Partial response or full response. Give for 1 year. By 1 year, whatever partial could have responded fully. After 1 year, because they have responded either partially or fully, go for 2 years. After that,
Taper down.
taper, stop, continue.
So you go on for at least 2 years and then start tapering it off. And every time you find that they're relapsing, bring up the
Bring up
dose
the
again.
dose.
Right? That's with CNIs. Okay. Now what about the
relapse? 30%, almost 30% relapse rates.
what is the role of Ritux? They have used Ritux,
FSCs.
MMF.
MMF they use.
First Ritux, then MMF. Okay, tell me,
First attacks, then MMF.
what is the NIH trial? These are the two conventional accepted therapies. Beyond this, nothing. What is the NIH trial in children in FSGS? So they have used high dose steroids, right? Pulse steroids along with cyclophosphamide, but not accepted. Ritux not accepted. Thing is, here someone should have drawn a line and said, if my patient is not responding, I don't want to expose him to more immunosuppression. It should have gone for gene testing. So maybe you are just using drugs which are not going to be effective. Okay, right now you've tried everything and 30 gram proteinuria, florid nephrotic state, what will you do?
Have you heard of medical nephrectomy?
So how do you do medical nephrectomy? Using high dose NSAIDs. Okay. So that's about FSGS. I don't think we can go further in your case about FSGS. But what strikes me as very odd is that the kidney functions are normal. You're saying creatinine is normal, which is odd. I only hope we are not missing a minimal change.
That's another question.
No?
Minimal change has so much of proteinuria. Why don't they develop minimal? How is the protein, tubular protein handling different in MCT and compared to others? What? Proteinuria, tubular handling, interstitial fibrosis, isn't it? All the textbooks. Why MCT don't develop?
Ma'am, because the mechanism of podocyte injury in MCD and FSGS are different. In FSGS, it is the fibrosis which starts off from the juxtamedullary globuli and it progresses. And there is a protocyte to podocyte spread of.
So it's a podocyte interstitial crosstalk, not just a podocyte effacement. You understand? So the idea is if you have interstitial fibrosis, the podocyte is injured. In MCD, it is not injured, it is just effaced completely. And it comes back also. So there is a difference. You can read all. These are all called podocytopathies nowadays. So sir is asking 39 grams. What are we missing?
It can just be a resistant FSGS which is resistant to all therapies. Presently, Patient is on steroids, MMS, and CNI. Still, he continues to have same range of proteinuria.
So is it safer to stop everything and just put him on NSAIDs?
Yes, sir. The genetic testing is awaited. We have sent the test.
Okay, suppose it is an MCD and this man develops, or now he develops, FSGS develops acute kidney injury. The creatinine suddenly starts going up now. So what crosses your mind?
Renal vein thrombosis.
One.
Hypoalbuminemia causing hypovolemia and prerenal.
Very good. One.
Infections causing sepsis and UTI.
Okay.
CNI toxicity.
Drug toxicities, which are
Which other
causing.
drugs?
Diuretics.
Okay, now since all of you are again talking about diuretics, let's go back to diuretics. With this, I think I would have finished, then you can.
No, sir, no, sir.
So we come back to diuretics. Now, when a patient comes to you and you start a diuretic, are you aware of what is known as the ceiling effect and what is the threshold effect? How much Lasix do you, or I should not say Lasix, a loop diuretic, you should keep on pushing before you say enough. So what I wanted to understand was that there is always a threshold effect for loop diuretics. There is a threshold. This threshold varies from person to person, disease to disease. So there is no fixed dose. Some may respond to 20, some may respond to 40, some may respond to 160. And then some may respond to intermittent, some may respond to continuous infusions. Now, why are we doing this? Because this is what we are doing when the dose of diuretics are given. There is a threshold at which it starts acting, right? And then it plateaus off. So, suppose your patient has started responding at 80. There is no point in giving 160. He is already plateaued at 80. And what is the rate at which you give furosemide?
1 milligram per minute.
What is the rate?
Diuretic naive patient, it is 1 milligrams per kg, and
I'm not talking about the quantity. I'm talking about the rate that you've gone and told the sister that please give 80 milligrams of furosemide.
we don't give stat because it causes ototoxicity.
What is the rate? That's what I'm asking you. 4 milligram per minute.
Not faster.
Not faster than that because of ototoxicity. And this figure you'll only get in Goodman Gilman, in no other book. Okay, with this I finish. We stop.
Eight, sir.
Eight.
You can finish, sir.
Whatever you want.
So let's give infusion and we'll take tacrolimus. Was the dose of tacrolimus adequate? What is the dose that we use for this patient?
We start with a dose of 0.05 to 0.1 milligrams per kg and titrate to
1 milligram, is it?
and we titrate toward trough levels of 5 to 8 nanograms per.
4 to 6 or 4 to not as much as
Now, if you all have any, you see what happens in this case presentation. I'll tell you how he has not completed. You come with the history. You should sum up the history. You should have the lab investigations with you, so that we can question you on the lab investigation. You should have the biopsy with you. Then only we can proceed further.
labs.
Yeah, he didn't have the lab, so you must carry the labs with you. And he came with a fixed that I'm going to present FSGS and this drug and that drug and this drug and that drug. No, we never reached your FSGS that
Differential diagnosis.
we stopped much earlier.
Did you do plateau R for this patient?
Yes, ma'am.
Negative, positive?
Now, you all have any questions
Sir.
on nephrotic syndrome?
Sir, while summarizing, is it wise to mention nephrotic range proteinuria or, as he said, nephrotic syndrome?
So, when you have nephrotic range proteinuria with edema, hypoalbuminemia, it is nephrotic syndrome.
But in case we have no investigations or we don't know the albumin
We
levels,
knew everything. We used 1.9, 1.6.
Patient came with NSR.
But you didn't give us the lipids. So that was not told to us. What is the major lipid abnormality in nephrotic?
Triglycerides.
So it's not cholesterol, triglycerides.
So he mentioned something about a venous infarct. Presumed it's a venous thrombosis. I don't know. So what should be the duration of anticoagulation in nephrotics?
depends. Provoked and unprovoked, sir.
One way to look at is provoked and unprovoked. So in unprovoked, what should be the duration in nephrotics?
In this patient, should we be continuing or should we be stopping?
Should we stop at 3 months, 6 months, 1 year? As long as there is a nephrotic state, you continue anticoagulation.
The other issue is also even if the nephrotic state goes away, then what do you do? Then what guidelines do you follow for his continuation of anticoagulation? Let's say this patient had a pulmonary embolism and now he is completely resolved of his nephrotic state. What is your guidelines for continuing anticoagulation in a patient with pulmonary embolism in a nephrotic state? 6 to 12 months, or is it same? Is it provoked or unprovoked? Provoked. So provoked, what do you do?
3 to 6 months.
8 to 6 months.
3 to 6.
So what we practice is that in non-nephrotic states, if it's a provoked, like example from your femoral catheters, it is provoked, you remove the catheter, you give for 3 months. If it is unprovoked and there is a pulmonary embolism, you continue for life. Alright? That's what she was asking for, pulmonary embolism.
Pulmonary embolism is immaterial with whatever your nephrotic state or whatever. Is it? Okay.
Okay. So we finished. Anything from your side?
Was
Nothing?
there any evidence of sagittal venous thrombosis or something?
Ma'am, I brought from the DNB.
Cortical venous thrombosis? Any questions from your end?
Okay, thank you very much. So next time do a lot of general reading, and the previous batches what we used to do, the student used to pass on the cases on WhatsApp, the case to everybody. So that everybody reads, make their questions, their doubts, and then they come. So since this was the first time it was being presented,
Is it in-
they have got a DNB. Have you all made your DNB group? So they pass the he's there. So they pass the case details in that group. So they read and they come. Thank you.